Good evening. Third class in the Harrison Nephrology series. This chapter 320, Interventional Nephrology. So in this chapter, Harrison have given the contents in the following way. First, in the initial few paragraphs, an overview about what is interventional nephrology, what is the procedure being performed. Then the history, how these have been evolved. Then few important and random points about peritoneal dialysis, catheter, complications, and a few important points about hemodialysis modalities and the procedures like catheter, fistula, AV graft, and a few practical points. So this I will try to cover it in a sequential way. Interventional nephrology. What are the procedure being done? Most of the procedure are related to the dialysis, especially the dialysis catheter placement. Tunneled catheter or the permacath placement, non-tunneled catheter placement, tunneled catheter in the jugular vein, femoral vein, lumbar vein, and the peritoneal dialysis catheter placement, performing kidney biopsy, transplant kidney biopsies, AV fistula, arteriovenous fistula creation, both radiocephalic and the brachiocephalic or brachiobasilic, followed by the transposition of the fistula. These were being initially done by the surgeons, but nowadays more and more procedure being done by the interventional nephrologist. Then AV graft and stenting plus minus. So these are all the procedures being done by the interventional nephrologist. Starting from the history, this is in the image you can see the initial the dialysis modality. They have used this rotating drum dialyzer. For this also patient need this you can remember as a hollow fiber dialyzer, how it have been evolved from this rotating drum dialyzer. For this also blood supply have to be from the patient, so we need the vascular access. So in the initial times the most difficult and the important thing was the creation of the vascular access. They have tried to take blood directly from the artery through various procedures. Subsequently, they have tried this Teflon shunt also between the artery and the vein before this invention of this arteriovenous fistula autologous. These were historical points. And subsequently, the radiocephalic fistula have been creating between the radial artery and the cephalic vein. The fistula, which supplies blood to the vein at a higher rate, from which it can be taken for the dialysis. And subsequently, arteriovenous graft. What is this arteriovenous graft? It is nothing but the connection between the artery and the vein through the some graft material. Nowadays, the synthetic materials are available. The hemodialysis catheter for hemodialysis was started in 1961. The peritoneal dialysis catheters was introduced in 1968. Initially, for the AV graft, they have used the buffalo vein, the carotid artery or the vein. They have tried in 1972 around. Nowadays, polytetrafluoroethylene is being used since 1976. The latest one, tissue bioengineered materials are being used in 2016. Angioplasty balloon for the AVF stenosis. Self-expanding stents are there, which are on the recent and the latest development. First, regarding the peritoneal dialysis. Here in Harrison, they have mentioned in the initial paragraph what are the modalities how which this PD catheter can be placed. It can be placed through fluoroscopically. It is nothing but a blind procedure where guide wire, uh, we can see the guide wire with the help of fluoroscope. Through that, we can place the peritoneal dialysis catheter. The second one, by the use of peritoneoscope. It is nothing but a scope through which you can see the peritoneum. Subsequently, you can place the PD catheter. Or through the laparoscopic procedure, similar to any laparoscopic abdominal surgery, or a open procedure. There are 4 modalities through which we can place the peritoneal dialysis catheter. And last one is the blind method, that is not being mentioned here. And the peritoneoscope, I will upload in a separate shot how it appears and all. And a further point, this is the patient who is having a peritoneal dialysis catheter. Peritoneal dialysis catheter comes out through the exit site. Here the inside it will enter. Here there are 2 cuffs. The catheter goes like this. It goes inside the abdomen and it goes under. There will be multiple openings. Here there will be cuff. Cuff is nothing but the thing which tethers the catheter into the skin. There are 2 cuffs. One is just below the skin. One is at the at the site of entry into the abdomen at the level of rectus sheath. See, here is the in this image they have shown just as if it is entering straight, but actually it have a subcutaneous course. There will be cuff inside. Here there are multiple holes where the peritoneal fluid goes, and there is the peritoneal exchange between the peritoneal capillaries and the peritoneal fluid. The peritoneal dialysis occurs. So here they have mentioned regarding the peritoneal dialysis catheter, where are the cuffs, what is the use of the cuff. And some random points they have mentioned regarding the infection. The peritoneal dialysis catheter might get infected at the exit site, or at the tunnel site, or the PD peritonitis can occur. They have mentioned something about the omental wrap. What is this omental wrap? Omental wrap is nothing but, wait, here there are the pores, outflow pores are there of the PD catheter. The omentum is here. The omentum just wraps it. So what happens? The fluid won't go inside. There will be inflow problem or sometimes outflow problem can occur. Basically, there is some obstruction to the PD flow into the peritoneal cavity. So that is omental wrap. And a long-standing problem is encapsulating peritoneal sclerosis. There is a sclerosis type of peritonitis which usually occurs more than 5 years. If the patient is on peritoneal dialysis for more than 5 years, there is a high risk of this EPS. At least for the medicine resident, they should know long-term complication of peritoneal dialysis, EPS. No other point is being mentioned in this Harrison. Next, regarding the hemodialysis catheters. The catheter is being made up of polyurethane, and this usually should allow blood flow of up to 400 ml per minute. For the dialysis, most of the time we need blood flow between 180 to 300 ml per minute. And the dialysis catheter are of two types. You can say non-tunneled one and the tunneled one. Tunneled one is also called the permacath, where there is a subcutaneous tunneling is there, so it prevents the infection. I will show like in the image, you will better understand. See, this is an example of a tunneled catheter. Here is the vessel entry side, here is the skin entry side. This is the subcutaneous part. So what happens, the chance of infection is less. If it is a non-tunnel catheter, the outflow comes just like this. And this is the arterial limb. There are 2 limbs, basically arterial and the venous limb. So this is the tunneled catheter. Tunnel catheter advantage is it prevents the infection. and the duration it can stay inside the body for a longer time. What are the vessel it can be placed? Ideally, internal jugular vein, right side or left side. Femoral veins can be preferred if the IJV is having some issue. External jugular vein, if the patient having good sized external jugular vein. Lumbar vein, rarely subclavian vein also. And one more point they have mentioned in this is here the tip. Sometimes if the tip, if instead of in right atrium, if it is in the major vessel, since the blood is sucking out also and going inside also, while sucking the blood out for the dialysis supply, the blood vessel wall might get damaged. So that's why the tip ideally have to be in right atrium, but there are chances if it is in the major vessel, sometimes lateral wall damage can occur. The blood vessel, the tunneled catheter might develop thrombosis. There is a chances of infection. And one more point they have mentioned is if there is a clot inside the atrium more than 2 centimeters, that have to be removed. But nowhere in standard nephro textbook they have mentioned this point. Like if there is a clot that have to be removed, but in Harrison they have mentioned some centimeter. If it is more than 2 centimeters, better to remove. And regarding further points about this tunnel catheter, they have mentioned only this thrombus and this subcutaneous tunnel tract. This fibrosis, what they have mentioned is sometimes it might cause occlusion, where we have to put the guide wire and correct it. That point is little bit confusing. Basically what they want to mention is there might be some kind of occlusion inside the catheter. It might have to be repositioned. If there is an infection, better to remove that. As I have told, chance of thrombosis. Atrium, if there is a big clot, that have to be removed. Next, regarding the atriovenous fistula and the AV graft. Fistula is the preferred vascular modality for the CKD patient. The most preferred is the radiocephalic. Radiocephalic is the distal portion between the radial artery and the cephalic vein. Why? Because if it is thrombosed, we can use the proximal part, forearm fistula or the brachiocephalic fistula. So other points they have mentioned is fistula also should able to supply a blood flow of minimum 300 to 400 ml per minute, but for dialysis, as I mentioned, we need most of the time 180 to 350 ml per minute. The blood will be coming from the artery going into the vein. And a few other points I have mentioned is in the brachial artery, the blood flow is 50 ml per minute. Once the fistula is made, it can increase up to 800 ml per minute in weeks. In case of AV fistulas, in case of graft, it might increase within minutes. This point Harrison have mentioned. And for CKD patient, there is a fistula first initiative. Better to start the dialysis with the fistula because of the long-term better outcome. And basically, it is the fistula first initiative, catheter last. Better to avoid the catheters because there is a high advantage with the AV fistulas. And regarding the maturation of the how to assess the maturation of the AV fistula, in Harrison the points are not clear. In standard nephrology textbooks, we use the rule of 6. After the fistula creation, ideally 6 weeks gap is required. 6 mm from the skin, the 6 mm in diameter the fistula, and the inside the fistula the blood flow have to be ideally 600 ml per minute by Doppler. This is rule of 6. These points were not exactly mentioned, but randomly they are mentioned in the form of AV fistula needs time to mature. And one more point they have mentioned is regarding the recirculation. What is this recirculation? Ideally, from the vein, it is going into the machine, hemodialysis machine. After that, we are returning blood to the body. Like it should enter into the upper part of the veins and it should go to the heart. But what happens instead of going above, the blood starts rotating here only. Blood goes to this way, hemodialysis machine comes back to the hand, then again to the fistula. This is called as recirculation. When it occurs, whenever there is obstruction over this area, whenever there is outflow tract obstruction, at least a medicine resident should aware whenever there is obstruction over here, or when there is a needling very nearby, the chance of recirculation is there. What happens when there is a recirculation? The dialysis won't occur because only some quantity of blood is rotating. So for externally for the technician and everyone, dialysis is occurring. But what is happening? The recirculation is happening. So it is also one of the problem with the AV fistula when there is a outflow tract problem. And one nomenclature I want to mention over here is this fistula parts. See, the blood from the radial artery entering the vein. This is the inflow part. The vein is going to the heart. This is the outflow part. This area between the anastomosis is called the juxta-anastomotic area. So inflow part, juxta-anastomosis, and the outflow part. And with the time, the AV fistula flow can increase from 600, even it can go up to 2000 ml per minute. How to detect it? Usually Doppler. Is it the normal value after a long time? No, it can increase up to, the range is from 600 to 1000. And what are the problems can occur with the fistula? There might be needle site injury. If there is a chronic rise in pressure, it might lead to aneurysm, dilatation. What Harrison have mentioned, chronic dialysis access disease, and they have given few images also. What happened? The fistula gets dilated. This is the image. This is a case series published by me and my friends. Here you can see how the fistula arm got dilated. There are around 15 patients who are having chronic fistula related problems. See, these kind of dilatation can occur. These are all the complication of chronic uh, increase in pressure inside the fistula, or whenever there is a outflow tract obstruction, this kind of aneurysm can occur. This kind of dilatation can occur. Whenever there is a dilatation over the chest and the upper limb, this indicates there is a chance of the central venous stenosis also. And they have mentioned what are the sites the stenosis is common. If there is a radiocephalic fistula, juxta-anastomosis stenosis is common. For brachiocephalic fistula, Harrison have mentioned the places where it can occur. But that is not important. Just you have to remember one of the complication of brachiocephalic fistula is stenosis. For graft also they have mentioned where all it can occur. It is just at the place where the graft enters the vein. Those are all the places where the stenosis can occur. So what are the treatment options whenever there is a stenosis? Ballooning can be tried, stenting can be tried. Not going into the details, at least these things can be tried. So whenever we do angioplasty or ballooning, the patency increases. Regarding the outflow stenosis, what is the outflow tract? Nothing but the vein to the heart. The stenosis can occur anywhere. Whenever there is a problem, there is a rise in the pressure, there is chances of aneurysm. And these are all the important complications as a gross concept you should aware of. What are the other complications of AV fistula? Since there is a connection between the radial artery and the vein, the patient can go for high output cardiac failure, pulmonary artery hypertension, aneurysms in the fistula is common. Since in the hand, artery supplying blood to the vein, if there is a very high flow, all the blood will go into the vein. It won't come to the distal part of the hand. Sometimes it can cause Steele syndrome, ischemia of hand. So how to reduce it whenever there is high pressure? See, this is the lumen. There's a high pressure. You reduce it. This is the blood vessel. You reduce it by putting a band. So that is called as banding. Reduce the flow by banding. One point I mentioned proline 20 can be used to put the band. And in the last few paragraphs regarding the practical points or approach, whatever the heading they have given, what they have mentioned is, as per the 2019 KDIGO guidelines, the concept is right access for the right patient. Suppose a patient is having congestive cardiac failure, we can't select AV fistula because there is a risk of failure, we have to go for catheter. Whenever there is a central venous stenosis, we can't go for a upper arm fistula, then we have to prefer a permacath in the lower limb. So the fistula have to be tailored according to the patient condition. And one important point is AV fistula needs time to mature, ideally 6 weeks. Sometimes if the patient is diabetic, poor vein, old female, even young female with poor vein, they also need more time to for the AV fistula to mature. Harrison have randomly mentioned 6 months to 12 months. Sometimes the time might be required for the fistula to mature. What is maturity? Nothing but it can be used for the dialysis. And the clinical examination is very, very important from the patient point of view for the fistula, whether it is suitable, whether it is functioning well or not, to detect that. How to detect it? The information in this is not clear. I will explain it clearly by inspection, then palpation, then by the two specific tests, pulse augmentation test and the arm raising test. And along with the palpation, the most important thing is the auscultation. Inspection, it can look red. If there is a hematoma, blackish skin discoloration, aneurysm might be there, dilatation of the venous segment can be there. What in the palpation? Palpation is the thrill. You can look for the thrill, you can look for the pulse. Thrill, presence of the thrill over the fistula. Usually it is continuous, it is having both systolic and diastolic component, it is usually continuous. Pulse, if it is hypopulsatile, it is not functioning. If it is hyperpulsatile, that means there might be some outflow tract obstruction. On auscultation, there is a hissing hissing sound on auscultation, similar to a PDA murmur. Continuous murmur will be there. If there is a gap between the murmur, that means some kind of inflow obstruction or outflow obstruction is there. Basically, a medicine resident should remember, by inspection, palpation and auscultation, you can find out the fistula pathology. Where all the fistula pathology can occur? It can occur at the inflow segment. It can occur at the outflow segment. It can occur at the juxta-anastomotic area. These are all the three common areas where fistula problem can occur. If there is an inflow problem, pulse will be low. If there is an outflow problem, pulse will be hyperpulsatile. Juxta-anastomotic, usually hypopulsatile. What are the two special tests? One is pulse augmentation test, another one is arm elevation test. Pulse augmentation test is to detect the inflow problem. How to detect it? Here I will explain. See, here is the artery. Blood is coming to the vein and it is going towards the heart. So when you upload the point A, the blood will be stacking over here. So the pulse became hyperpulsatile at the point B. That is basically the pulse gets augmented. Suppose if there is an inflow problem, only fixed amount of blood is coming, the hyperpulsatability won't be there. So whenever pulse augmentation test is showing augmentation, that means it is normal. Whenever it is not showing any augmentation after uploading point A, that means it is some pathology, abnormality is there. Second test is the arm elevation test. This I will tell later. Arm elevation test. A patient who is standing, if the patient keeps the limb by the side, the veins might look prominent. But once we ask the patient to raise the arm above the head, the prominent vein might get collapsed. Why? Because the outflow tract, all the blood is going into the heart. Whenever there is an outflow tract obstruction, this vein will be prominent. So this is the test to detect outflow tract obstruction. So this is what they tried to cover in those paragraphs. Finally, one point they have mentioned is, since whenever a CKD patient comes for a long term, since AV fistula is the vascular access modality of choice, better to preserve the veins, better to avoid any intervention over the central veins, better to avoid the cannulation. For the medicine resident, avoiding cannulation in the radiocephalic area, at the elbow, at the forearm is very important. They can use the wrist or the hand area so that they will preserve the vein for the creation of the fistula. So these are all the important points covered in Harrison. After this video, once you see study the Harrison, you will get the concept better. See you in the next video.